So I really, first of all, want to thank Millie, Corey, and the staff at AIBD for the extremely kind invitation to talk today. And I was actually asked to talk about these topics: predictors of natural history and severe disease in clinical practice, predictors of risk for disease adverse events, predictors of treatment efficacy, and currently known IBD genetic markers and serologic tests of interest. However, these three right here really touch on the same idea, that million-dollar question: which patient, when I see them in the clinic, is going to have a smooth course, respond to their therapy, be great, go out and be wonderful, and which of these patients is going to be cycling in and out of the hospital, end up in the operating room, fail my therapies? How do I know? What I really want to emphasize is, what are the goals of our treatment? I think it's good to start with what are the goals of our treatment for our IBD patients. And we want to restore normal bowel function, we want to improve their quality of life, and most importantly, we want to induce and maintain a steroid-free remission. And all of this is ultimately to modify the natural history of IBD, to avoid hospitalizations, to decrease their surgeries, to eliminate the disability that these patients can have with this disease and maintain their independence with affordable cost, to minimize long-term exposure to steroids, but also to minimize the side effects and risks of the therapies that we put them on. So with this in mind, let's start with predictors of natural history, disease severity, and disease adverse events in clinical practice. So first of all, most, not all, but most, over 50% of our Crohn's patients are going to have a complication of their disease within 20 years of their diagnosis. So looking at Crohn's predictors of higher risk of disease progression, we see age, younger than 30, the more extensive disease location, which I'm going to cover in a second, the presence of perianal or severe rectal involvement, deep ulcers, a prior history of surgery, and any stricturing or penetrating behavior, any fistula, any strictures, as this all indicates higher disease activity and therefore a lower likelihood of response to therapy, as we'll talk about. Now notice, none of these are symptoms that the patient might have. So a patient might present in your office and say, I feel great, but if we see that they have multiple of these risk factors, we want to be a little bit concerned and maybe, as we'll talk about in a second, monitor them a little bit more carefully. So what is some of the data behind all of this? Well, this is a population-based study that was done in Olmsted County, Minnesota, of over 300 Crohn's patients that were followed for about 9 years. And they were looking at factors that predicted intestinal complications, so penetrating or stricturing disease. And what they found was that disease location, especially disease outside of the colon, so disease in the terminal ileum, the upper GI, and the ileoclonic area, and to a lesser degree in this population, perianal disease, were highly associated with complications. A separate study from Olmsted County actually followed a group of over 300 Crohn's patients for about 25 years and looked at the risk factors associated with surgery. Male sex, disease location, again, any disease outside of the colon, smoking, penetrating disease, and early steroid use were all significant risk factors for surgery in this population of Crohn's patients. Now, we also have predictors of more aggressive disease and ulcerative colitis. These include younger age at diagnosis, the presence of pancolitis, a higher disease activity as measured by Mayo score or UCIS, the presence of deep ulcers on endoscopy, and this is really important. When you see these patients in the hospital, one of the reasons to do a flex, in addition to looking at CMV, is to look at what the disease burden is. These deep ulcers are highly predictive of going on to colectomy surgery. Low albumin, elevated CRP, and early need for hospitalization for their course. So all of these then naturally lead to, well, then how can I predict which of these are predictors of treatment efficacy? Now, we've all seen this triangle. At the bottom are what we consider to be our more benign treatments or medications. They have variable efficacy, and then we escalate up to medications that we view as more global and perhaps have more risks. And we've traditionally thought of saving those more aggressive medications only after a patient has tried and failed the more benign medications. But think about that. That means a patient has to get sick, fail something, and get sicker potentially before we would escalate up to something else. We now know we may not want to start at the bottom for some of these patients who have these predictors of more aggressive disease. We know, for example, that we might be starting earlier with these more global therapies with our more aggressive medications in Crohn's disease and more aggressive Crohn's and more aggressive UC. And this brings us to this idea of patient selection, which is really critical here. We may not be able to predict which medication will work in every individual patient, but we can predict as a group what are the patients are going to need the more aggressive therapies, the more aggressive monitoring, and start higher on that triangle. Looking at it a different way, using an illustration I think all of us have seen before, ideal treatment windows here, when you're going to get your best treatment efficacy, are before you have complications. Or after surgery, when you can think of it as, okay, we've got this clean slate, we got to get back in the game. We've got to prevent them from going on to get their second surgery. Unfortunately, over half of Crohn's patients who have the first surgery will ultimately go to a second surgery. I consider that a failure of us to get this disease under control. In contrast, if you're chasing a complication, treatments are going to be less successful. So what can we do to predict treatment efficacy? Well, actually, we can do a lot using predictors of natural history and severity we just went over. And when we're talking about Crohn's disease here specifically, but a lot of this will apply for ulcerative colitis as well. So first, we can look at the age at diagnosis. Upper GI and small bowel location is more common among our younger population. So you may want to consider, should I be a little bit more aggressive with my therapy? Should I be doing proactive therapeutic drug monitoring? Maybe I want to do more aggressive evaluation of their disease, maybe do an EGD or a small bowel evaluation in addition to a colonoscopy. Colonic disease tends to be a little bit more common in our older population. Here you may want to think about what are the potential side effects? How can I maximize efficacy but minimize side effects? Along similar lines, you want to determine where exactly is the disease location. L1 refers to isolated ileocecal disease. Importantly, L4 is going to refer to those upper GI locations, esophageal, gastroduodenal, jejunal, all of which are associated with greater morbidity if untreated, and therefore warrant a little bit more aggressive therapy. And then with Crohn's disease specifically, you want to look at the type of behavior. Inflammatory disease responds best to medical therapy. Stricturing disease, we're all aware, can either be inflammatory or fibrostenotic. Fibrostenotic is the least likely to respond to any therapy, the most likely to require surgery. Penetrating disease is also aggressive, and steroids are not going to help you here. Again, you may actually be looking at surgery. Now, we often think of surgery as a failure, but remember, post-surgery is an ideal treatment window to get back in the game and make sure that we get our patients under control. And finally, remember, perianal disease itself is also considered aggressive disease behavior. It does not improve with steroids. You're going to want to get control over that pelvic area, likely with biologics and maybe antibiotics as well, and monitor with appropriate radiographic imaging. Once you have appropriate disease severity assessment and you perform that, it's easy now to go back to our predictors of more severe disease and disability for our Crohn's and UC patients and consider more aggressive treatment and with combination therapy, with proactive therapeutic drug monitoring in those high-risk features to decrease that overall inflammatory burden and prevent disease progression. And have a frank discussion with the patient. Risks of these therapies may seem very scary, but there are real risks to the disease itself. And those absolute risks of the disease are much, much magnitudes higher than the absolute risks of our therapies. So being able to talk to a patient and present them with this information and say, look, we're really worried about this. You have predictors of having a complicated course. We want to avoid surgery, goes a long way to bringing that patient into the discussion. Additionally, consider treatment efficacy. When you're looking at treatment efficacy, you want to look at other factors that are going to influence the pharmacokinetics of the biologics we may use. This includes sex and body size, but also low serum albumin and a high baseline CRP. These increase drug clearance, so you're likely going to want to consider monitoring your drug levels, maybe escalating early, and watching for antibody formation. And additionally, especially in UC, we know that those deep ulcerations are going to predict a poor response to therapy overall. So you may want to consider higher drug levels and getting early preparation with your surgeons, getting them on board early. Now finally, a question we often have is, are there any IBD genetic or serological markers to help guide us beyond these clinical markers? And there are actually a lot of serological tests, a genetic marker, even a commercially available panel here. 3 of the classics include p-ANCA, ASCA, and OMPC. As you all are probably familiar with, p-ANCA we tend to think of it a little bit more in ulcerative colitis. 2/3 of UC patients might be positive versus only 25% of Crohn's. Crohn's patients who have this may be more likely to have colonic disease, whereas ASCA seems to be a little bit more specific for Crohn's, just like OMPC. With regards to genetics, we have NOD2, which was then renamed as CARD15, the first genetic defect that was identified on chromosome 16, associated again with Crohn's disease. And then there's a commercially available panel that uses a combination of these to sort of generate a predictive score for patients. Now, I've italicized HLA-DQ-A105 down at the bottom because I'm going to talk about that separately in a second, but let's focus on the ones above that. Currently, there is no role for using serologic or genetic tests in diagnosing IBD. So take, for example, NOD2 CARD15. Majority of your Crohn's patients actually are not going to have those mutations. The absolute risk, even if you're a homozygote, is less than a 4% chance of developing Crohn's. It's much less if you're a heterozygote. Likewise, the serological tests, the ANCAs, the ASCAs, have at best a middling sensitivity and specificity. So that means in the general population where IBD is relatively rare, you're going to have a very low positive predictive value. This translates into a high rate of false positives. That means patients who get unnecessary, potentially harmful additional tests, confusion, and anxiety about a false positive test. There's also no role in using these tests as the sole test to differentiate between ulcerative colitis and Crohn's disease. We often run into this after all of the other clinical behaviors have been taken into account. Maybe there might be a role in saying, okay, let's try this out. But as the sole test, these should not be used to differentiate between UC and Crohn's. Now, there have been some studies correlating some of these markers in particular disease phenotypes. For example, ASCA has been associated with stricturing penetrating Crohn's. ANCA may predict poor pouch outcomes in IBD-U or IBD indeterminate, and certain immune reactivity is associated with complications in pediatric Crohn's. But there's no role for monitoring the disease behavior because we don't know how changes in the serologies are going to actually correlate with disease outcomes in IBD. I do want to take a moment, however, to talk about HLA-DQ-A105, which needs to come up with a better name. This has actually some real repeated promise. This was a candidate gene discovered in a GWAS, or Genome-Wide Association study in Europe, as part of the PANTS study, or Personalizing Anti-TNF in Crohn's Disease. The goal of the study was to identify Crohn's patients at an increased risk of developing antibodies to TNFs. So they conducted this GWAS study in over 1,200 anti-TNF naive Crohn's patients. And it's important to note that these were patients of European descent, and they found that HLA-DQ-A105 was associated with a significantly increased rate of developing antibodies. This was found repetitively whether the patients were treated with adalimumab or infliximab, whether they were on mono anti-TNF therapy or on combination therapy with an immunomodulator. It has been repeated in smaller studies, both within this population as well as in other studies, so there are repeated outcomes of this. Now, there's some real limitations here. First of all, the largest study in one of the repeated cohorts are in patients of predominantly European descent, but in these smaller replication cohorts, it has borne out. So this may be something that's widely generalizable to our IBD population. Secondly, there may be some issues right now with getting insurance coverage for it, so don't order it without maybe checking to see if insurance covers it. But this really has a lot of promise in helping us personalize and predict who may develop antibodies at 1 year for our anti-TNF therapies. So in summary, not all IBD is equal. Stratify the risk factors for disease severity. Remember the age of diagnosis, the disease location, disease behavior, and stratify your treatment choices along that pyramid accordingly. We get so scared of the drug therapies that are at the top of the pyramid, but really we should be fearing the outcomes of the adverse events associated with the active disease. Currently, most of our serologic genetic tests are not useful as standalone diagnostic or prognostic tools, but keep an eye out for this HLA-DQ105 because it really may help us in sort of figuring out which biologics to use in our patients.